For decades, the medical literature has relied on a strict anatomical definition of cervical radiculopathy. In 1996, Levine defined it as pain in a dermatomal distribution. Later, Boekduck asserted that cervical radicular pain is perceived in the upper limb. That literature established a heuristic that most clinicians still use today. When screening for a compressed nerve in the neck, they expect the patient to describe pain radiating from the cervical spine straight down the arm. If a patient arrives with pain localized to their shoulder blade and no arm symptoms, they failed that heuristic. Their scapular pain is almost immediately categorized as a facet joint issue or a muscular strain. A 2025 scoping review analyzing 86 independent studies reveals a serious flaw in that diagnostic filter. By requiring classic arm pain to trigger a cervical radiculopathy protocol, clinicians are missing the actual onset of the condition, delaying correct treatment. To understand the actual presentation of this pathology, researchers extracted data from 81 papers that mapped specific regional pain distributions in confirmed cervical radiculopathy cases. This chart shows exactly where patients experience symptoms. The neck and arm are the top two regions, appearing in 88% and 85% of studies respectively. Look at the third most common region. Scapular pain is reported in 72% of the literature on confirmed cases. That high prevalence is entirely absent from foundational texts. The landmark 1994 Rochester Epidemiological Survey tracked cervical radiculopathy patients for 14 years and never once mentioned the scapula. The 2025 review also examined how these regional symptoms combine. Isolated arm or neck pain is incredibly rare. The vast majority of cases present as a multi-region pattern: neck and arm, neck and scapula, or all three together. The data proves scapular pain is not a rare anomaly. It is a core, primary characteristic of cervical nerve root compression. The core reason the scapula gets entirely ignored by clinicians goes far beyond static anatomy. It is fundamentally a problem of timing. In 2006, Tanaka and colleagues tracked the chronological evolution of radicular pain from the exact moment it began. They found that in 70% of cases, Phase 1 consists entirely of pain in the neck and the scapula. Phase 2, the classic radiation of pain into the arm and hand, happens much later. For 55% of these patients, arm symptoms do not appear for a week or longer. In 21% of cases, the classic arm pain required for a standard diagnosis does not show up for a full month. When a patient presents with isolated scapular pain, they often already have cervical radiculopathy. The clinic has simply caught the pathology in its earliest stage of evolution. Since the scapula acts as an early warning system, we need to know exactly which cervical nerve roots are triggering it. This chart maps regional pain distributions to single cervical nerve roots. The C7 segment holds the highest proportional relationship to scapular pain. C4, C5, and C6 contribute at a lower prevalence. Although rare, C8 produces a highly distinct pain pattern in the lower scapula. The presence of scapular pain provides a predictive localization map, strongly biasing the diagnostic probability toward a C7 root compression prior to any MRI confirmation. There is a valid neuroanatomical reason clinicians misinterpret these early symptoms. Isolated periscapular pain has historically been the leading indicator for cervical facet joint syndrome. This image shows the established referred pain distributions originating from the cervical zygoapophyseal, or facet joints. Now look at the corresponding map for C5 through C8 radicular pain. When we place these models side by side, the clinical confusion makes sense. There is a massive spatial overlap targeting the medial and superior borders of the scapula. Facetogenic pain is mediated by the dorsal ramus, sending nerves descending into the scapular region. The cervical disc is innervated by the sinovertebral nerve, a ventral ramus branch. Irritation here refers pain to the exact same zone. Because the neuroanatomy creates identical regional pain maps, relying on spatial location alone is insufficient to differentiate early radiculopathy from facet syndrome. To break the diagnostic tie between facet and radicular overlap, we now have to rely on dynamic mechanical evaluation. A standard Sperling's test evaluates nerve root compression. However, the literature shows clinicians usually only consider the test positive if it actively reproduces pain in the arm. The 2025 review provides a sharper heuristic. If a patient's most bothersome pain is located in the scapula and is modified by moving the neck, the positive likelihood ratio for radiculopathy sits at 2.3. Favorable modification through provocative movement is a strong predictive signal. Upgrading our clinical examinations to actively look for the reproduction of scapular pain, not just arm pain, significantly increases early diagnostic accuracy for radiculopathy. This blind spot extends beyond the clinic and into how we design research. A common method to quantify radiculopathy in trials is combining neck and arm pain into a single visual analog scale. That combined metric acts as a systemic filter. It actively excludes patients in the early stages of nerve root compression who present with isolated scapular pain. Future prospective studies must decouple these symptoms. We need a distinct scapular pain scale and mandatory documentation tracking the exact timeline of symptom onset. When we stop treating scapular pain as a muscular distraction and recognize it as a primary indicator of cervical radiculopathy, we can accelerate time to treatment by weeks and improve outcomes before arm symptoms ever appear.